So this last talk is going to actually probably go pretty quickly because Phil Boudreau in his talk sort of gave an overview of a lot of liver-directed therapy. So I'm going to sort of focus on the fact that you need to understand the whole menu. And I think we've gone over surgery, we went over PNET surgery, we went over small bowel surgery, we went over radionuclide therapy. We're going to leave chemotherapy for you to watch on YouTube, and then we're just going to end up with liver-directed therapy so that we can generate any additional questions that may be relevant to that topic. So the objective is to really clarify why liver-directed therapy is important in patients with metastatic neuroendocrine tumors, the types of treatments that fall under that umbrella of liver-directed therapies, the factors that weigh into what types of liver-directed therapies we use, and then some of the emerging LDT techniques like histotripsy. So why LDT is important, I think that Boudreau really kind of touched on this, is that if patients are going to struggle long-term in neuroendocrine, it is usually because we lose control of the liver. So I was not born professionally into neuroendocrine. I am surgical oncology, but I was within the division of transplant, and my foray into neuroendocrine was people being referred to us in Indianapolis because they needed to be transplanted because they had either liver failure or bi-organ failure, not necessarily from the disease, but what had been a decade or more of treatment. So I think that the liver becomes our focus. It doesn't become our only focus, but it becomes our focus because controlling the liver is super important. So liver-directed therapies are not new in this disease. Some of these platforms have been around for decades. I think we've gotten better at them. We use them more judiciously. We understand the goals of treatment when we're using them, and now we have more things in our pocket. So liver metastases are significant drivers of mortality. Carcinoid syndrome and really needing those rescue shots and things like that is usually because of the activity that is within the liver. Some liver-directed treatments are considered as good as resection in certain cases, so therefore it saves you the morbidity associated with an operation, and they can be used alone or in combination with other treatments. The types of liver-directed therapies that have sort of been mentioned, but they fall into categories. You have embolization, of which there are 3 different platforms of embolization. There's ablative techniques, of which thermal ablation is just using a bunch of heat to the point where the tissue can't stand it anymore. There is electroporation, which I'm going to talk to you about because it's going to be, I think, one of the things we're going to use more. You've got histotripsy, and then you've got targeted radiation that she did not touch on because it was predominantly PRRT, but has also been proven of benefit in patients with metastatic tumors to the liver, not necessarily just neuroendocrine. So I'm going to start with embolization because embolization probably has the longest track record in neuroendocrine. And so for people that have had it, they're going to already have had this analogy, and people that don't understand it, this is your primer. So they access this highway of arteries in your body through some sort of access. One of our interventional radiologists uses it through the arm, the other uses it through the leg, but it's really no different than how they access the heart to put heart stents in, or the arteries in your head and neck to do stents or procedures in your brain. The difference is that they're making a turn at the liver, and the liver is uniquely separated into 8 segments, and each of those segments in fetal life is like swimming around, all with its own little blood supply, and then I don't know, somehow miraculously before you're born it all merges together into this 3-dimensional organ. But that the anatomy of it is a bunch of those different little branches, very similar to a tree. So an interventional radiologist can use that under image guidance and then can direct therapy into different sections of the liver to kill tumors. And so if you were to look up here, this is just a cross-sectional image so that you can see this tumor here, and then there's this tumor. You may or may not be able to appreciate the little tumor here, and I put them on this little fake body over here. So I've got a little tumor here, and I've got this tumor here, and I got this tumor here, okay? Then they're going to go in, and they're going to shoot a study. And then they literally light up, often like little Christmassy ornament type things. So right here you can see this one, and then you can see this. And then this is them delivering the therapy. And then for those of you who have it, This is the analogy where you go to the state fair with your little air rifle and the little arcade with the targets, and pretty much the interventional radiologist is going as close to the target as possible to get that target without damage to the adjacent structures. Yes, and then your postoperative film, which you can't really see with the lights on here, is that they start to look actually, you can almost see them more clear in this picture. Well, that's because that's a dead tumor, so the interface between a dead tumor and a live liver becomes more prominent, so you can see it better. So oftentimes, when I'm showing patients after they've undergone a liver-directed therapy, you can say, oh, now I see it, where it was a little bit fuzzy on here. You can actually see it much clearer on here. That is a response to therapy. The expectations with embolization is cytoreduction. Cytoreduction just means that we are trying to deliver therapy and diminish the number of parking spaces or the disease burden in that site, whereby a systemic therapy like lanreotide would be potentially more likely to keep the remaining disease in check. We have used it in combination with PRRT because we don't want the liver to be the hungry hippo of all the PRRT particles. So oftentimes we will decrease the disease burden in the liver, whereby we would be able to hone the PRRT to extrahepatic sites. It has an 80% objective response rate. It is an excellent choice if what you're trying to do is from one moment to the next, they go happy, happy, happy to very unhappy. And so it's got an excellent response rate. That response rate drops to around 52% at 6-month mark, and there are a lot of reasons why that could happen that we would discuss in individual patients. But that for those people that are in the 52%, that can be all someone needs for years of time. So that durable response can last for years of time. And then there is the control of symptoms. So there are some times where I will say, hey, we should consider liver-directed therapies because your syndrome is worse. It doesn't matter whether or not the things are growing, your symptoms are worse, and therefore one of our goals is going to palliate those symptoms by decreasing the burden of disease in the liver, and oftentimes we'll go for the hottest tumor under those circumstances. So when it was initially studied, there was really no significant improvement in overall survival in patients that were treated with lanreotide or a somatostatin receptor analog alone versus liver-directed therapies. But you have to remember that none of those trials were going to be powered long enough because people live so long to look at that survival advantage. So a lot of it was in the control of symptoms. The people that underwent liver-directed therapies had substantially greater control of symptoms than those that stayed on the systemic therapy alone. So it's to drive down serotonin levels so you don't have as much risk of carcinoid heart disease, decrease intestinal manifestations of carcinoid syndrome, and then decrease the flushing as the two major types of carcinoid syndrome. The complications of embolization, the post-embolization syndrome happens in over 80% of patients. That can be low-grade fevers, nausea, abdominal pain, and worsening of already baseline fatigue. And then in a subset of patients, it really doesn't happen that often, probably less than around 10 or 15% of the time, you can get infection in that dead AO tissue leading to a liver abscess. It is way more common in patients with a history of biliary intervention. That's why we are somewhat more tempered in people that have had like a Whipple procedure for pancreatic neuroendocrine tumors or have had a lot of biliary intervention. And then it's more common in large tumors where you have a lot of devitalized tissue. The types of cases that are good for embolization are predominantly the people that are very syndromic with carcinoid syndrome, patients with multifocal where whacking a mole with more ablative techniques is just going to be less satisfying and probably less effective and more morbid. And then in larger tumors that have a more mature blood supply that are less amenable to ablation just because they're too big. Thermal ablation comes in two varieties. I would really just focus on this one because we've kind of gone away from radiofrequency. That's just showing radiofrequency waves in order to kill tumors. It is a thermal ablation, meaning that the waves just generate a certain amount of heat, and it doesn't matter whether or not it's a tumor cell or a skin cell or a bone cell or whatever. It just can't take the heat. In tumors up to 3 centimeters, that's been shown to be as good as taking that tumor out surgically. In larger tumors, not so much. But the problem with radiofrequency ablation, it comes out in all of these tines. And so this tine is delivering a radiofrequency, this tine, this tine, this tine, this tine. And so if the tines are somehow not positioned as nicely within the tumor, you'll get just an uneven type of thermal ablation. And if any of those tines are close to critical structures, you can get a lot more complications. Microwave is a little bit different. Microwave is using microwaves. It's got a single probe here. It doesn't do the tine. You're just going to stick that somewhere, and you're going to turn on that machine, and it's going to burn a cannonball that size in there. So microwave is a little bit problematic because you have no change in the thing. So if it's right up against a really critical structure, oh yeah, that doesn't care. It's just going to heat that critical structure. So the location is really important with microwave because you are generating high degrees of heat. And then cases that are good for thermal ablation are tumors up to 3 or 4 centimeters. I will tell you that there are very strong ablation programs out there that will use multiple generators and multiple probes, and you can make like something that looks like a snowman using multiple probes and getting this overlapping thing, and it is amazing, but it is super labor intensive. So you can use multiple probes in order to get larger tumors, but that it's not generally good for things that are large to close to large blood vessels, bile ducts, or the colon, stomach, or duodenum, because ultimately that heat will either damage those adjacent structures, or else the blood vessel will work like a heat sink, and it'll suck some of the energy out, and the ablative capacity goes down. SBRT, targeted radiotherapy, has been studied in clinical trials and is now along the NCCN guidelines for both primary and secondary tumors of the liver. That is how I describe it. Now I'm going to be embarrassed. It is how I describe it. It is kind of like a video game, kind of like Star Wars. It's coming along a 300-degree gantry where they can tend to control the angles and or the depth of the beam. So you are doing high intensity radiation therapy to a very tight spot. And so I will tell you, when we have location issues next to blood vessels, SBRT is really quite a good alternative compared to ablative techniques. So when you're talking about it right next to this blood vessel that's going up into your heart, that's actually a pretty reasonable place to do SBRT and a horrible place to do ablation. And then, as Kendra could probably tell us what all this means, but the different colors, I think, are the intensity of the radiation in that site. And it's going to say, well, how much radiation is going to go here versus here versus here. And so you are trying to target it as intensely as possible into the target area, and then as it goes away from that area, the radiation and therefore the radiation damage would dissipate. So this is just what it looked like before, and radiation is about shrinking things away, and so oftentimes it may take a while to see it because, as I say, it works slowly but lasts a long time. It sometimes this type of a change will literally continue to show regression over like months to a year. Not to get, okay. So the limitations of SBRT are very much the location. I put this on there so that you can understand that in many pictures you're like, oh, the liver's like separate from everything else. No, everything like squashed all together. So because the liver literally sits from the front to the back and all the way from the right to just past midline, you've got a lot of stuff that is squished up in there. And so depending on where the location of the tumor is within the liver, it can't be too close to the colon, the stomach, and the duodenum are the usual spots that make SBRT difficult. It's got to be at least a centimeter away from those structures. Histotripsy, which is, we've gotten a lot of buzz about histotripsy. Histotripsy is using ultrasound waves. I think everyone sort of understands what lithotripsy is. That is low frequency pulsed ultrasound, and it is like a jackhammer. So you want, it goes, and if you've ever had lithotripsy, that's really what the machine sounds like. And that is because it's trying to break up something that is the consistency of a bone, like a calcified ureteral stone. Histotripsy is high frequency pulsed ultrasound, so it's got a buzzing sound to it. It generates what they're calling as a bubble cloud, and it is predominantly pretty much shaking the innards of a tumor and causing what is called cavitation. So it is non-invasive because it is coming, all those ultrasound waves are coming from outside of the body. It destroys tumors through something called cavitation. It is non-thermal, non-invasive, no radiation, and it has less adjacent tissue damage. And that is because Ultrasound, kind of like bone, it really doesn't like bone. It kind of reflects off of bone, but it respects things that are different texture of collagen, so it can go right up to that blood vessel. But the difference between a tumor collagen and the blood vessel collagen has it core to stop right there. So for certain places of the body, like a prostate or a liver, things where you've got a complex anatomy, I think that it's really dealing with a lot of the limitations of what some of those ablative techniques are like. So this is what the machine looks like. All of your stuff gets loaded onto this thing. This is the little head. I tell you, it looks like a virtual reality head, and this is what it's looking like when we are doing it under the studies. You're using an ultrasound, and you are sort of finding your angle. You're bringing this head of the machine in, and pretty much like locking your car into a car wash, it pretty much is, once it's locked in, it can pretty much invariably target that area that you have chosen. Now, I will tell you, thanks Mr. Taylor very much for explaining his experience, but that there are some nuances. You got to be able to see it with ultrasound, and it is a little bit hard to get the car into the car wash lane. But once it's in there, yeah, it pretty much is as we thought it was going to be, and it is going to wind up being, once I think we have a lot more savviness with it, it's going to be, I think, a great tool for patients with tumors in particular areas. Irreversible electroporation is another thing where you are using, I think it's a sound wave, and you are doing it. It used to be really kind of cumbersome because you needed two probes and they had to be exactly a certain distance from each other before the field would work. But the concept of electroporation is that you're pretty much using a technique that is going to blow holes in the membrane of the cell, and then it like leaks out like, I don't know, a squid that you just poured salt on. And in the process of doing that, it sort of involutes and dies. It is another excellent technique. It was just really cumbersome, required it to be done open. It couldn't be done percutaneously, and it was really just kind of a pain in the behind. Not a pain in the behind of a ram, but a pain in the behind. And so it really got out of favor. Now they've gotten it onto a single probe back in the tours, so the probe looks very similar to a microwave probe. I think it is probably as easy to use as a microwave probe. So I think for patients that are not particularly great candidates for histotripsy because of the location of a tumor and our ability to see it under ultrasound, I think electroporation is going to be a great option. And we are now, and the next thing I'm asking for from all of the people willing to help us is to get an electroporation device. The treatment pokes holes in the membrane, and the cell death is via leakage of that intracellular material. So then let's get to what is called the abscopal effect, because that's what probably is the biggest buzz. I don't want us to think that is unique to histotripsy or electroporation. It's just relevant to that. The abscopal effect has been seen predominantly in renal cell and melanoma, where you can treat one lesion, and for whatever reason, that treatment that you are delivering causes your immune system to react to it, driving then a response in lesions that were not part of your targeted field. So this is just a picture of someone with 3 sites of disease, even though I think the brain is irrelevant because they're the blood-brain barrier, but we're going to ignore this one up here. But that you would end up treating something within an organ. This is going to be the liver. So you have this one tumor, but that in the process of blowing holes in the membrane or shaking it to death while causing cavitation, how I describe it is it releases the identifiers. We call those antigens. So it releases identifiers that are particular to neuroendocrine cells, or that neuroendocrine cell in particular. Then your immune system is going to see that trash. It's going to come and try to gobble up that trash, and it's going to try to recruit an army of immune cells. And those army of immune cells, like Boudreau talked about with vaccines, are going to then target cells with a similar identifier. So the abscopal effect is when you get response to a tumor that was not treated by treating the tumor that you treated. And so as such, then you get shrinkage of tumors that are outside the field by treating the tumor that was in the field. Electroporation and histotripsy are both associated with abscopal. As Dr. Boudreau mentioned, is that neuroendocrine is never going to be included in the trials that are ultimately getting some of these things through the FDA. So we're usually coming back on the other end saying, hey, that all sounds really exciting. It doesn't really change our ability to offer it because it's still going to kill tumor cells, which is great. But that our ability, I think we will be the program that will define that in the thought that there is an immune response to it, because most of our patients are going to be neuroendocrine. So in summary, liver-directed therapies are a standard of care method. If I were to say one thing about embolization, is that there is no actual difference in response whether or not you use chemoembolization, bland embolization, or radioembolization. Some of them are a little bit better tolerated. We tend not to use radioembolization in people that we want to make sure they are amenable to PRRT, because those are both radiation platforms. But that I will tell you that in higher grade tumors, we will often use radioembolization. The expectations of response are high, often greater than 80%. The grade of the tumor is less relevant. The grade of a tumor is not going to be more or less amenable to heat damage. Is not going to be as damaged to shaking damage. It's not going to be as relevant to things where you're blocking the blood supply. Higher grade tumors are often more resilient at getting around embolization therapy, so the durability of the response in that subgroup is a little bit lower, but the vast majority of neuroendocrine are really well treated with liver-directed therapies. It can be used alone or in combination with other treatment. We are not the only program that uses it in combination with other treatments. And so oftentimes it's just what's the goal of therapy and how can we possibly get you there? And the tumor location is the main factor that limits most, if not all, of liver-directed therapy and ablative techniques. And that is the extent of our day.